Yeah, Jay, I made you the host. Now you can share.
Okay, sir.
Yeah, perfect. So
Yeah.
now it's all yours. And I just request all of participants to be mute. And any questions, you can share that in the chat box. Then we can discuss in the end. I think with me, one of our mentor, Deepak, is also there. So we will have a discussion in the end. Okay. So it's
Yeah.
all yours now.
Okay, sir. Hello, everyone. The basic question when we talk about today's this thing is why PRF in the first place? Because in my opinion, slowly it is going to become a necessity in every clinic across our country. Reason being is it's the same logic when we talk about initially, if there are a lot of, I hope there are a lot of general dentists out there. We used to do a lot of manual BMP during root canals. Ultimately, we switched over to endomotors. Same applies when we used to use those Kodak films for X-rays, IOPA. Today we have RVGs in almost every clinic. The world is slowly and steadily shifting towards autogenous bone grafting or augmentation. When we talk about more and more autogenous is going to come up in the future, and hence PRF does really justice when we talk about that. It's definitely a paradigm shift, and this is going to lead everyone one day. And two things which I really feel is going to be a necessity in every clinic is one is the PRF machine, second is the 3D printers, because we are going to go digital sooner or later, and then everything would be guided. That is one of the major reasons why all of us, we should have a little bit or some knowledge about PRF. When we talk about it, it all started with PRP in the start, and it's been in the market since 2 decades now. When we talk about PRP, that is platelet-rich plasma, angiogenesis, it was leading to angiogenesis, which was leading to a rapid recruitment of a lot of cells, which help in proliferation, differentiation into various cell types, and helped in tissue regeneration. But there was a big disadvantage over there. It had to, there were a lot of anticoagulants which were added to it. And we all know anticoagulants are suppressors of clot formation over there. Hence came PRF into the picture, and this is the reason why it is called as the second generation platelet concentrate. In the past 5 years, a lot of research has been taken place into it, a very vigilant research rather. The coagulants which were added, anticoagulants added, have been eliminated. The preparation time has become very less over there. It's very less, it's pretty less over there. And it has enhanced, and different centrifugation speeds, etc., 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 have been added to it, which we are going to see in the further slides. And this is how PRF has become one of the most predictable. When we talk about, if you want predictable prognosis with respect to certain treatment protocols in perio and implant dentistry, it's a go-to thing. It's primarily used for, as we all know, periodontal defects, soft tissue issues, and bony defects. So it doesn't do anything to the hard tissue per se, but when it is mixed with a biomaterial, for example, a graft, it really enhances the properties of a biomaterial. When we talk about biomaterials, we really want it to be stable, to be less reactive to the body. Basically, in short, we don't want any allergies. PRF, it's your own blood. It's a patient's own blood rather. It will have no side effects onto anything. Plus, it is freshly made. So it does have its own benefits. When you talk about our field, when implant dentistry or anything, wound healing is one of the most important things. When you read across and go across the whole slide, it is divided into the 4 main aspects to it. This is hemostasis, inflammation, proliferation, and maturation. Indirectly, this is what is 1 sigma all about. We'll discuss 1 sigma later on, but that's how healing takes place with respect to our body. it demands the various cell types to come together, perform a very complex process over there with a three-dimensional matrix and soluble growth factors along with it. When we talk about this, in short, it only means in one line, if I have to just sum it up, it is uneventful healing. When we talk about this, PRF does satisfy or gives a green tick mark to all those three criteria what we are looking for, the various cell types, a three-dimensional matrix, extracellular matrix, and soluble growth factors which facilitate regeneration. Now, platelets have been described as the key components affecting the early phases of tissue regeneration, which are important for hemostasis by fibrin clot formation, and it does secrete a number of growth factors. PRF serves, as I mentioned, it does serve all the three criteria. It gets tick marked over there. It is serving a three-dimensional fibrin scaffold, basically a net sort of a thing which holds everything together. Includes all the autologous cells such as leukocytes, macrophages, neutrophils, and platelets, and is a reservoir for natural growth factors which have a slow release over a period of 2 weeks, 14 days, 10 to 14 days, which are very important for the wound healing when we talk about healing by primary intention. So that is where this whole thing comes across, because when they say that when you place an implant, it is extremely important to see it for the first 10 days. It's not about only implant, but anything, even if you do extraction or we do any sort of surgeries wherein sutures are given, we do tell the patient to come after 1 week or 8 days or 10 days. It's nothing but healing by primary intention. And this is where it helps to get probable results over there. When we talk about it, as I mentioned, PRP, these are the types of platelet concentrates which we get from the body. PRP, as we mentioned, it was the first this thing that it underwent its own journey of evolution. It became LPRF. L is nothing but it stands for leukocyte PRF. Then it was APRF, that is advanced PRF. We have something called as liquid APRF, which we use it to make sticky bone. That's not IPRF. IPRF is a little different. That is used for all facial aesthetics and for those hair transplanting they use. So when we come across this, as I mentioned in the past, the growth factor release, what we are talking about, these are the results. There are different research is done on all the centrifuges across. One of the most important aspect which we see is, irrespective of whatever the machine they used for the centrifugation, the quality of the test tubes was very important. We'll be talking in detail about that as we go ahead with the presentation. But this slide is pretty important out there to see why the APRF. And when I talk about APRF, this is the same machine which we have in the institute. It's from Dr. Joseph Shukron. It's called as Duoquattro. And the reason why APRF is really good is because the way it releases the growth factors over a period of 10 days is genuinely amazing, because when we want all the cells to be, everything to be proper in a certain way, as we mentioned, uneventful healing, wound healing. Come across to the components of PRF. There's a cell types, what we have are platelets, of course, leukocytes, and a red copper cell base. We have a provisional extracellular matrix called as, it is made up of, it has fibronectin and vitronectin, which has its own benefits across. And there are bioactive molecules, or in short, growth factors, which we were talking about, is PDGF, platelet-derived growth factor, vascular endothelial growth factor. There is transforming growth factor beta, BMP2s, insulin-like growth factors, etc. So this is something which has been ever, the best part is there are no side effects of it. Since it is autologous, there are known to be no side effects. When we talk about PRFs, this is how it looks like. The topmost layer is called as an cellular plasma. Nowadays, anyone who's using PRF would just eliminate these things. When you have a PRF plot, when you're talking about a PRF plot, the cellular plasma layer has been thrown away, or it's not been used, it's been discarded. But some recent advances has given a really big revelation over there, and it has been used. So in the last of the slide, as we are towards the end of the lecture or the presentation, the cellular plasma, we talk about the PPP, that is going to be one of the most important things and supposed to be a game changer. So in case in the future, if you have PRF machines, please don't throw that. Keep it. It has its own importance. Then we have the fibrin clot, the PRF, and a red cell base. And the steps involved are phlebotomy. When we talk about phlebotomy, it's nothing but a venous puncture, what we do to draw blood. Lots of things I have gone through, because we didn't get that sort of what we say training with respect to phlebotomies in the college. So I have realized one thing: please never draw blood from the wrist. The veins are they collapse easily over here. So it's always to be from the cubital region, from the elbow basically over there. You collect the blood into the test tubes, and there are centrifugation protocols as per to the type of PRF you want to harvest. So if you want a clot, there are different settings across. If you want a liquid PRF, there are different settings across. We'll come to that as we proceed. So this is what I was talking about. The triangle, what you see, please try to draw blood from those areas, or else it is going to be a very messy situation, which I have been through, and trust me, it is not good. This is a short video to just if you before starting the video, I would just want all of you to appreciate the fact that we have used a double tourniquet technique over here, because we couldn't find the veins over there. We couldn't locate it properly. Hence, we used a double tourniquet technique over there. Now, the whole importance of this was that we couldn't palpate it properly. So what I did was, even anyone else can also do it. Take a warm towel, or basically soak a towel or a cloth into warm water, put it across the patient's hand in this area, and keep it there for at least 5 minutes. Use those double tourniquet techniques, and you'll be able to, after some time, definitely you'll be able to palpate the vein, rather than just hitting it over in order to get that vein across. I'll just play the video. Now here it is not visible, but I could palpate it definitely, because of the same thing which I told you. So this is something which is really good. The vacutaneous, this is called as a vacutaneous. The collection of the blood is pretty fast over here, and it is very accurate with respect to it's just 10 ml. There is no spilling of blood, no fussy stuff over here. It's not at all messy. It's good. One mistake what we did over here was we did not apply adequate pressure at the venous puncture area. We should just keep that area stable. Now, if you see, that has a green cap on it, and this has a red cap on it. See how fast the test tubes get filled up with the blood. Please try to use these if available. and they will exactly collect 10 ml blood. See, we should have released the tourniquets first, and then we should have done that. We should have released the tourniquet first. This was a mistake which I did. This is our machine. And it's important to balance out on the opposite direction. If you don't do that, it's not going to be proper because it needs to be balanced. So we've just put up another which we filled up with water. This machine has its own, it's already pre-programmed with respect to what you want. So it is 1300 RPM for 14 minutes. And once after the whole centrifugal process is done, it sends out a little alarm and automatically the machine opens. And that is how you have harvested what you want. So these are the PRF plugs with the red caps, and the green ones is the liquid PRF, liquid APRF. These are APRF plugs. Since we are using this machine, it's APRF. If you're using any normal centrifuge, you're going to harvest LPRF. Come across, I'll just explain the difference once the video is over. Just take a normal 2 ml syringe. You've got the liquid PRF with you. These are the PRF clots, so you can call them slugs as well. Okay, so there's some amount of red cell base attached to it. Please never cut it. One of the major reasons, one of the common mistakes is to cut it. Never cut it. Always scrape it the same way. Always scrape it. Never cut it. The reason is there are a lot of leukocytes which are displaced in that area. So you have a good cell population over there near the red cell base. Now we want to make membranes out of it. So you have to apply pressure. And in the meanwhile, I'll make sticky bone. Now, what is sticky bone? You have a bone graft with you. With that help of the bone graft, since bone graft is particulate in nature, it is very difficult and clumsy to handle it when you are doing it for the augmentation procedures. You mix it with either saline or any other medications. But over here, when we talk about this, when you put a liquid PRF over it, after some time, it becomes very easy to handle. It becomes stable. It doesn't scatter around. So when we are using liquid PRF along with this, just layer it slowly. You put one layer of this, again put some bone graft. And spray the liquid PRF over it. And just keep it for some time. Maybe 5 minutes is really good amount of time for it to form a sticky bone. Just close it. There is no contamination around. And this is how a sticky bone looks like. The particulate bone, which was totally very difficult to handle, has now become such an easy task. You can mold it the way you want to. I guess it is in the coming videos. It's not in this video. You can mold it the way you wish to any shape you want to. It is easy to handle. It will not scatter around. Moreover, it is loaded with growth factors and a lot of other things which we really want with respect to wound healing. There's leukocytes, etc., etc. See how dimensionally it is stable. The proof. You can lift it as well. Not a single bone particle will fall off. No wastage. So coming back to it, there are different things which you can make across. You saw the PLF clot, what we got from that red tube. If you compress it, it becomes into a membrane. If you apply a little bit of pressure, it becomes a plug which can use for once you've extracted a tooth and you want to place an implant later on, basically not doing an immediate one over there, and you want to do a lot of socket preservation over there, put across that plug inside. The clot can also be used for I have done one case wherein I just put the clot, I cut it and I put it, and that is how I did an indirect sinus lift over there. No graft was used over there. A little bit amount of graft was later on pushed. So I got beautiful results with that. You can use the whole clot, the slug which we got, and you can shove it inside when you remove after disimpaction, the mandibular disimpactions. When we do, there's a lot of bone, and after healing, a lot of distal bone loss is observed on the second molars. To the distal of second molars, a lot of bone loss is observed. In order to prevent that, you can put across that clot inside directly and just suture it away. No need to do anything. Then there is sticky bone. You saw that it's used for grafting. This membrane can also be used, the ones which we applied pressure and then we made a membrane out of it, for a lot of other root coverage techniques also. The research is on. You can use the membrane when you do you can cover your vestibuloplasty bed when you do it. So it has a lot of benefits out there. We'll just come across a few these things. So this is how a membrane looks like after you have just applied a lot of pressure onto it. And you can use it to enhance, when you're using titanium mesh. So a lot of times the titanium mesh will cause a dehiscence because of it. The dehiscence is caused because of the titanium mesh. You can apply over it the titanium mesh when you're doing a 3D grafting over there. There is a video again for the same. It will help the gingiva over there. It will not irritate the gingiva, act as a barrier over there. Second, this is a sticky bone, which we all saw recently. And you'll even see, I guess there's a video again of it when we are doing an augmentation procedure. Yeah, I guess this is the one. So we are over here making, I guess, a sandwich graft. Now what is it? Is onto this sticky bone, you put up this membrane across and you compress it. It becomes really way more robust. When you want to fill in a larger defect, it helps over there. This is more dimensionally stable. So imagine if you have large defects over there, and I don't know whether you guys saw it or not. In the start, when we used the amount of biomaterial, the bone graft which was used, so you save out on a lot of money as well for yourself and the patient, and the conversion rate becomes higher because the bone graft is used pretty less. It's not much, and you get really a good result out of it, because if you're using those particulate grafts without the PRF thing, you end up using more. Okay, again, this is how they use the same video, just a different way. Please don't take that red cell base. You're not supposed to take. Again, slide it across. Do not scrape it. Sorry, do not cut it. Scrape it across. Don't cut it from that area. And I guess in 3 minutes, we have got the sticky bone with you. That gel is called as PRF exudate. It's really a good thing. Now, this is what I was talking about when we say that you want to do socket preservation. This is how you do socket preservation over here. So you get this box, the APRF box or whatever it is, and there are little, yes, so you put it across into this and apply that a very gentle pressure, optimal one across. After some time, you will get those plugs which you can easily put it inside the socket. Not too much of a pressure, only a little bit. This you can easily put it across any extraction socket for socket preservation. And this is what I was talking about, that we had augmented over here. So there is a titanium mesh which you can see. We'll be just placing this PRF membrane over it, which will not irritate the gingiva. It will help increase the vertical thickness of the gingiva as well. So thicker the gingiva, better it is for us. It has varied. This particular patient had a cardiac issue, so we were very skeptical in using anything else over here because we don't want any allergies to come across. This is how things were. And with that additional, in case if you are left with any additional liquid PRF, liquid APRF, use it to just inject it across your surgical side after suturing. Nothing, no side effects. It will rather help in your healing. It will help across. So when we talk about the application and we have to sum it up, the soft tissue management, the periodontal defects, the hard tissue management, only when it is combined with a biomaterial, there are no evidences that it will give you, it will help in hard tissue regeneration over there. Of course, it will only help when it is combined with the biomaterial. A lot of complication management, surgical, I'll just show you a few cases across on how it is helped with the complication management over there. It can be used as a filler to increase the bulk of anything. Socket preservation we saw. Vestibuloblastis, it will act beautiful. Adjunct to implant protocols. I have seen a lot of clinicians, before placement of the protocols, they spray the implant surface with the liquid PRF across, and they put some amount of PRF inside the osteotomy as well. Apexification for all the pediatric dentists out there or any other, it's working out well. We have a pedodontist from Terna Dental College who is doing a study on this. He's placing PRF plugs inside the canals for apexification procedures. So it's basically something which would really suffice to a lot of things onto different levels, like for example perio, OS, and definitely now pedo and endo as well. Now we'll start with some case presentations over here. So this is what we have, the pre-operative situation over here. We can see the left side. It's not, hello. The left side over here is patient has missing teeth, and this is not really looking good. After we remove the temporary prosthesis, we have a major defect over here. And the worst part, it is in the aesthetic zone. So it has to be managed in a certain good way. And the green line is where the gingival line is over here. We want it to be more coronal, and it is not going to be so. This defect is both horizontal and vertical at the same time. It's not good over here. Anything two things are there. The gingiva and the bone both rely on each other. If the bone is resorbed, the gingiva will too resorb over there, and vice versa. So we need to do a hard tissue augmentation. Automatically, we'll get the soft tissue profiling over here. So when we talk about this, a lack of keratinized gingiva, this is a proposed treatment plan. Since there is a 3D defect, we'll use a composite graft, xenograft plus alloplast. We'll do a layering technique. We'll put air PRF liquid over it, which will become sticky bone. Put over there, let it heal. Once you have got the bone, there's implant placements, and post the implant placement, you can go ahead with the soft tissue augmentation, and then you can convert those FP2 into FP1 prosthesis. So this is what we want. We do not provide soft tissue product to be achieved to avoid FP2 prosthesis in the future, and this is how we'll go ahead. So there's a full thickness flap raised. The defect is pretty evident over there. And we did decortication over there when we do it. So before the decortication, a lot of soft tissue release was done. When you do a soft tissue release, scoring, what we say, you have to get the flap all across it, because you have to that space which will be acquired by the bone graft are biomaterial over there. So we need to cover it up completely. So that's why we did it. And this is the PRF liquid. That's my mistake. It's not IPRF, it's APRF liquid, which we have prepared over there at 700 RPM for 3 minutes. We mixed it with xenograft and we applied it over there. So before applying, we did a decortication so that some amount of blood is coming out there, so that it becomes really, there is a blood supply basically to the graft, and we covered it up. At the post-op healing, we gained 3 millimeters over here, horizontally and vertically. If you see over here, this is after 1 week, and this is the pre-op, this is the post-op. So this is what wonders PRF will do. The healing is really good. And this is a second case. There is a huge defect over here on the low mandibular area. After revealing, if you can see, full thickness flap were raised, and this is what the whole area was. It's very thin over there. The insertion, it was approximately less than 20 Newton centimeter, the insertion top for the implant which I had got over here. Took this, made it into a PRF sticky bone. We made a sandwich composite graft. We placed it. There was a titanium mesh covering over it and a membrane, and we closed it up. Now, this was done just before COVID, and then COVID struck. We had a mesh exposure over here. So things get a little bit worried over here. The only good part was that the implant was stable over there. Nothing happened to the implant, luckily, but the mesh had exposed. The gingiva doesn't look good at all. Same thing which I did over here. This time I was in Mumbai, back to my place, and the patient is my dad, by the way. So used the another centrifuge which I could have my hands on to, created PRF and sutured it back. So when I sutured it back, this is what it looks like after 5 days. This is what it looks after 10 days. And this is what it looks after 2 months. So it definitely does wonders with respect to our soft tissue healing. And this is what the proof is all about, that PRF after 8 weeks will show you the same amount of quality of the gingiva what you have in your mouth. So it does have, indirectly, if I want to say it has some amount of pluripotency potential over there in order to create what is missed of the same type. And now PRF can be used with temporary crowns as well. It has multiple uses over here. And so you can just, when you have done an immediate case and you're worried about in the aesthetic region, you're worried about the soft tissue profiling because it usually collapses over there. And you don't want to graft it at that time, please make a PRF membrane, put it across, put a hole across into middle, use your temporary crown and just screw it inside, and it will just stay amazing. It has, as we have seen in the previous slides also, and it is there in the literature as well, that it has profound soft tissue enhancement with respect to your even in the aesthetic zones. Now this is, you can use it when we are talking about the applications of PRF. This is what I wanted to share. This case is done by Dr. Deepak sir. There was a perforation into the sinus, maxillary sinus, when we were during the course the student was doing, and there was an perforation during the direct sinus lift process. Sir has managed it with PRF. It just goes and sticks to the Schneiderian membrane, the maxillary sinus membrane. Again, no side effects. It's totally natural. Two things. Well adapted inside the sinus. Grafting was done and was sutured back, and everything was fine. So it's definitely something which really could be a game changer if we have it across these things. Anyways, when we come across to how does centrifugation speeds or G forces impact the quality of PRF? Now, all this while we did talk about the benefits, the types of PRF, the applications of it, what all it contains. But in the first place, when we talk about how it's supposed to be made, so according to the study, one of the most interesting findings when quantifying cells found in the PRF matrix histologically was observed that the majority of the leukocytes were found at the bottom of the fibrin plot. When I say bottom of the fibrin plot, it was near the red cell base thing. So it becomes very, it's not evenly distributed. So because of this, again, some amount of research was done, some amount of studies was done in order to have more specific and more uniformly formed PRF, which has evenly distributed cells across the whole clot. So centrifugation speeds were changed, they were modified, and according to it, everything had been under the research. Now, when we talk about this, even the growth factors had a major this thing. So it was concluded that at low speeds, you get a good amount of cell distribution, and the growth factors are also released in a certain way, in a slow way, in a progressive way. So there is one more point to it. The test tubes play a major role over here. When you are using a test tube which has an internal coating, or which is made up of plastic and which has an internal coating of a silica or a silicon, it is proving to be a big issue over there. So test tubes do play a major role. And if you are using high speeds, no doubt you will get a bigger clot, you will get a heavier clot. If you weigh it, you will get a heavier clot, but the quality of the PRF is not good. If you ask me, you can use that as a filler with respect to filling up the disimpaction sites, but not the extraction sites, but not definitely with the biomaterials. Now, that is how, this is what I wanted to talk about. The fixed angle centrifuge and the horizontal centrifuge. When we talk about the G forces, there are two things which we have to really understand. Is today in market, we have PRF machines which have, when you place the test tubes inside, they are either from 33 to 45 degrees centigrade. The one which we have in the institute is 41 degrees, well, not centigrade, 41 degrees in the angle. You will, over here, you will always get these cells displaced over here because of the G force applied in this way when it rotates in the centrifuge. So they came up with the horizontal centrifuge, and this led to the evenly distribution of the cells. And it is proven over here. That is one of the major reasons. When you have a lot of cells over here, you're not supposed to cut it over here. You're just supposed to scrape it from this area. On a fixed angle centrifuge, platelets, white blood cells, and red blood cells accumulate on the back of the Walsh tube. This leads to improper cell separation, reduction in platelet and leukocyte concentration. This is what we're talking about over here. So now in a horizontal centrifuge, the cells separate much more efficiently throughout the entire tube. This leads to better layer separation and also favors cells that are evenly distributed throughout the clot. This is the histology of it, and we can definitely see over here, this area is more crowded. The distal end is more crowded over here, whereas this has evenly distributed clots. This is how an LPRF membrane looks like, and this is how an HPRF. Now, when we talk about HPRF, any new person, any new scientist coming across, a clinician coming across, getting its own changes into it, and it names according to what he wants to. So please don't get confused. It's just PRF, but when we talk about HPRF, it's just used by an horizontal centrifuge machine. Nothing special about it. Actually, it is a lot special, but nothing special with the name. So this is how a horizontal centrifuge machine looks like. And the G forces, when we talk about, this is what matters over here. The RCF, when we talk about the RCF, it is rotational centrifugal force. This is from the rotor axis, it is too high. So higher the rotor, higher this thing, the G force applied is optimal over here, but it has to be. Now, two things come across over here. One is your time, what time you're supposed to do it, and what are the centrifugation speeds. So we have come across and zeroed it down to low centrifugation speeds. When we talk about low centrifugation speeds, it means if you want a liquid PRF, use 700 RPM. If you want a PRF clot, you use for 1300 RPM. Now, the time plays a major role over here. It depends on the machine which you're using. But if we have to go through this thing, 13 minutes is more than enough. 8 to 13 minutes is more than enough. The clinical significance of tube selection. The PRF clots produced in glass tubes produce larger membranes than silica coated plastic tubes, and the selection of this proper tubes had much a greater impact than the centrifugation device. When we just talked about it some time ago, that test tubes play a major role when we are talking about the quality of the clot. Over here, the membranes which were used, the plain glass tubes which were used, had the better quality, and the membranes or the clots which were produced inside a plastic which had a silica coated plastic tubes, they had really a bad quality of PRF. And this is how I'll just show you across the studies which have been done. There have been 5 studies which have been done since 2000, I guess, 17 across. The PRF membrane produced with fixed angle centrifugation, again, the same thing, horizontal centrifugation is proving to be better. Now, over here, when we talk about the contamination, this is when the contamination comes across. So if we are using something autogenous or autologous, and PRF has so many benefits, using those plastic tubes which are silica coated is going to spoil everything, because it is leading to cell apoptosis. The silica is being displaced or being precipitated inside the clot, which is not good at all. Because this is the whole point over here when we talk about if you're using anything inside the patient's mouth, so it has to be inside the humans, it has to be totally natural. But when we go to the pathology labs and they collect our blood for other smear collection stuff, the coating of it is not a big issue over there, because we are not going to use it again inside our body. But over here we are using, so it has to be plain glass tubes, not plastic ones. The reason is the silica coating actually shed these things into the PRF membranes, thus embedding silica particles at a quite significant level with the PRF clots. These silica coatings have a high affinity for cell membrane walls, causing apoptosis and reduction in cell proliferation. Both silica and silicon and addition to interior of PRF walls led to nearly twofold reduction in the clot sizes. Furthermore, it has shown that it is reacting with the PRF membrane, hence causing some foam-like residue over it, which is not a good thing. And this is how it looks like when you do it. When you see it, these are all silica particles, silicon particles inside the PRF clot. So please avoid using any plastic ones from the manufacturer. Please ask, we want simple glass tube, plain glass tubes. These are the different new tube. We have Vinojet, all these companies. Please be very sure. Please read the manufacturer's instructions properly. When we talk about the recent advances are something which is pretty quite shocking for me also, because when we talked about it's a 10 to 14 day slow release of growth factors, and then PRF is dissipated across, because but over here they have enhanced the life of PRF by 4 to 6 months. This is a new development and a protocol which involves an additional heating process following centrifugation, where the platelet poor plasma I told you about, we usually throw that. When I started in the lecture, we throw that area, but this is going to be a game changer. And I said it earlier, this is how it is going to be. That platelet poor plasma layer, that the acellular plasma basically is heated at specific temperatures to denature and reorganize the albumin inside it. This drastically extends the working resorption properties of the PRF, and it extends till 4 to 6 months. By heating and denaturing albumin, a modification in the secondary structure after heating transformation liquid PRF into tridimensional structure. This is how things have been, and this is the thing which looks like this. So after you have got those PRF clots ready, or whatever PRF you want to make, that is liquid PRF or PRF clot, you just put it into it. It heats it at a certain degrees, and once this is heated, it is left to cool down for at least a couple of minutes, and then it is used. I'll just show you how it is. So you have got the centrifuge whole blood and you've got CPRF. Now CPRF, again, as I told you, if tomorrow I come up with something, some discovery and something new, I'll call it JPRF. So please don't get confused over it. CPRF is nothing but concentrated PRF. And if you see, these are horizontal ones. So it is used in the horizontal centrifuge over there. The upper the acellular plasma has been collected. It's heated for 75 degrees into the machine I showed you in the previous slide for 10 minutes. Then it is allowed to cool. And once it is cooled, it is mixed with that liquid PRF, what we had got. The acellular plasma which was heated is mixed with the liquid PRF, and an albumin gel has been formed. Now they named that as ALB PRF. So this has proven to be amazing with respect to your bone grafting, and it stays on for 4 to 6 months. That is what we wait for usually after placing an implant or after doing some sort of and performing some sort of an augmentation procedure, 4 to 6 months, and then we re-enter that area in order to go ahead with the processes or whatever we are going to do ahead. So this is the recent advances which we have come across. And if we have to conclude this whole thing, it's the we'll go from, please use plain additive free glass tubes. Horizontal centrifuge will produce a clot which will have even distribution of the cells throughout the length of the clot. PRF clots produced at low speeds will have more concentration of platelets, evenly distributed cells, and increased level of growth factors. That is 1300 RPM at 8 to 13 minutes. 8 minutes is for liquid PRF, 13 minutes is for the clot. Always scrape from the red cell base, never cut, because if you do not have the horizontal one and you have the angular one or any other this thing, or basically not the pre-programmed machine, if you have another machine, please do not cut, because you are definitely having, you're making an LPRF out of it, and you're definitely having the major cell concentration towards the red cell base. So please scrape it off and do not cut it. PRF has no side effects. It's 100% autogenous or autologous and gives a predictable prognosis. Cost effective, definitely yes. because you buy that machine for once and it can be utilized into it has a lot of applications across. Then most importantly, when you are using PRF, your bone graft, the biomaterial, what you're consuming, what you're using for the patient is reduced to a different level. Because if you saw in the video, we only used half of the vial from that bone graft of that 0.5 cc, and we created a good amount of sticky bone in order to cover a very large defect over there. So it is definitely cost effective. It makes the biomaterial more user friendly. That's what we want. We don't want it to scatter around. It's any which ways, it's very expensive, and we can weigh its worth in gold. So bring stability to the augmentation. And I just end this over here. Thank you.
Okay. So can you make me the host, please? Jay?
Yeah.
Yeah.
Just a sec.
You have to go to the participant list and I'll be there.
Yeah.
You made me? Okay.
Yeah. Yes, sir.
Yeah. Thank you so much. So I will share my screen. Okay. Sorry. It was a very informative, basic presentation, very nicely done. I hope the participants have definitely got more information now. Any questions? Let me see any questions. There is only one. Okay, what is the temperature of acellular plasma warmed to? You have an idea?
75 degrees centigrade.
Okay. Anybody wants to ask any questions among the group? Okay, so what is the difference between now the new machine, Jay, and compared to the old one?
Sir, this machine, what we have in the institute has it's 41.3 degrees angled, and the new machine, what I just showed over there, has horizontal. So the G forces, when it is applied, when we talk about the forces which are applied over there are at an angle. So this is a fixed angle which we are talking about, which we have. So over here, definitely with the pre-programmed everything settings and all, and the test tubes which we have, we are getting advanced PRF. But when you want a concentrated one, it's with the horizontal one. So horizontal ones will have a more evenly distributed cell population as compared to this, what we have today. But it's good enough to go, what we have. I will not force you to buy that one again.
Okay, good. So thank you so much, dear. Thank you so much for your time. And I would like just to give you a token of appreciation. A hard copy will be sent to you.
Sure, sir. Thank you.
Yeah, this is a certificate. This is a certificate of appreciation from BOCI. Of course, you are our host, but you deserve one. And we will just send us your address and we will send you the hard copy. And sure, I think one more question. Yeah, TPRF. Somebody has asked me, Dr. Ritika has asked, what is TPRF?
I have to read about it.
Okay.
To read
so
about
you can unmute yourself. Anybody wants to ask and speak also, not a problem. Anybody wants to talk something?
Hello, Jay.
Hi, sir.
Hello, sir. Good morning, sir.
Good morning, Deepak. Tell me.
Jay, if we are using injectable PRF during osseointegration phase, how often we need to inject?
I can't hear you. Sorry. Can you just repeat the question?
If we are using injectable PRF,
yes, sir,
during osseointegration phase, how frequently we need to inject it since we don't have the option of warming the acellular plasma.
Yeah, sir, I have done this one case. If you allow me to share, I'll just show it across. The soft tissue profiling, I did it thrice. So the day I placed implants, every month I used to do it. I did it. So if you allow me, I will just share across it on WhatsApp group if you want. I did it thrice,
Okay.
and the tissues have been really good. So, but
Okay.
again, the question comes, is a patient going to come every time to you and it's going to allow you to draw blood? So now this patient was a near relative, a family friend. So I just convinced her to go ahead with it. And another thing, sir, I would want to tell is I have started with, after implant placement, I've just started with vitamin D capsules for anyone who is about 40 years of age, one capsule per month. And I've seen beautiful results with that also. So along with this,
Okay.
if you combine this, it's a very good thing. I would just send across the images of that on the WhatsApp group. I have done it thrice, the PRF injections, the liquid PRF injections, which I did per month basis. Each monthly I have done that. I have got good soft tissue results over there.
Okay. Okay. Thank you.
Yeah. We know that you have a knack of drawing blood and convincing the patient. Isn't it, Deepak?
Yes, sir.
So I think nobody can beat you with that. Convincing and
Yes,
drawing
sir.
the blood. Any
Sir,
other question?
I have one more doubt, sir.
Okay.
Sir, if we can save the blood banks, save the blood, preserve the blood mainly.
Mm-hmm.
Hello.
Yeah, I'm
if
listening.
we can draw blood once and we can can we store those IPRF and all?
Sir, उसमें वापस problem वही होएगा, additive procedures. The whole point is we don't want anything
Yes, additive procedures.
They will add anticoagulants to it or something, and that is going
Okay.
to be a big issue over there.
Yeah.
Okay.
I think this was also discussed once with Chokran also. I heard his lecture. He was talking about that we have to do it fresh extractions of the blood and doing it rather than using a stored blood, because somebody asked that if they have a stored blood and all, can they use it, or we can store it once, take it out and keep it. I think that is the problem. Yeah.
So the whole point over there is that silica coated test tubes are going to prove to be an issue, because what we are using over here are the glass ones, and the ones which go for the smear collection, they do have some of the internal coating to it. So that gets added to it, and we've seen what silica is doing over there.
Yeah. Okay, I think it was really informative. I think I need inputs from the participants, those who are there in the chat box. How was it? Anything addition should have been done? And because Jay is still a learner, but actually I salute him and appreciate his confidence. I just told him 2 days back that can you present, and it was already ready yesterday, and I really appreciate that for you. And thank you so much, all the other participants, and thank you, Deepak. And we will see you maybe in a week's time for the webinar from Kulud, which was postponed today, about the smokers and use of smokers, implants and smokers. So thank you so much, all.
Yes.
Thank you, sir.
Thank you, sir.
Thank you so much.